Good morning. My name is Jamie Gillespie, and I am here to talk to you about advanced examination skills for special age populations, particularly these pediatric age groups as well as geriatrics. I'm doing this talk with you today because nurses and providers are often missing important assessment findings because each age group is very special and very different. So not only do we need to approach these age groups differently, but we need to assess them differently as well and know the big differences between physical, cognitive, social development of these children. We should be able to identify what's normal and abnormal. Starting with infants from birth to 12 months, very important to get a birth history as well as prenatal care. All of your health history is going to come from the parents or caregiver. We're going to assess the cord, assess the fontanelle, both the anterior and posterior, the shape and symmetry, as well as circumference of the head, assess for any congenital anomalies, making sure that this little patient got their newborn screenings completed, any errors of metabolism that need to be treated. Congenital anomalies, heart defects are very common. Assessing for any murmurs. Some murmurs, of course, can be benign. Checking all these reflexes. When do they begin and when do they go away? Cause for concern would be if there's a delay in these reflex, if the patient is not having this reflex or an abnormal reflex. Making sure that vision and hearing. Vision's simple, just making sure if the baby can follow you, should be able to see. They still see pretty close up. Naturally, their vision is going to go farther and farther away the older they get. And hearing, if you hear a loud clap, they should startle. That gives you a pretty good indication that they can hear. Assess the family for cultural beliefs. As well as immunization schedule. There are a lot of immunizations in that first year, making sure they're on schedule. Car seat safety is very important, making sure they're in an infant seat in the back seat, rear facing. And always assess for non-accidental trauma as well. Bilateral hemorrhages, building fontanelle, being more lethargic are all big signs of non-accidental head trauma particularly. Any non-ambulatory infant should never have a broken bone or welts on their back or any patterns, of course. Of course, there are some congenital things, like Mongolian spots, of course, can be a normal finding and can sometimes be mistaken, but knowing those things are very important. We should be using our growth chart. Anything below the 5th percentile or above the 95th percentile are reasons for concern. We should assess is the patient breastfed or bottle fed or both. We're using distraction and play. These babies really don't like to be poked at too much. Making sure that anything that could be painful or unpleasant should be saved for last. For example, we don't want to start with the rectal temp and make our patient angry, and it's going to make it harder to assess them. Do that last. Moving on to toddlers, starting at about 1 year of age and going to 3 years. These patients are starting to develop stranger anxiety. They should be afraid of you. They don't know you. They don't want to touch you. Or sorry, they don't want you to touch them. Again, making sure any painful or invasive procedures are done last. They're gonna want to play and be comfortable. So showing them your equipment, possibly demonstrating on a patient or on the parent or caregiver or a stuffed animal, showing, we're going to do a blood pressure on the stuffed animal. Let's listen to mom or dad's or the caregiver's heart and lungs, looking in their eyes and ears, just to show the patient that this is not going to hurt, that we're trustworthy and try not to be scared. We're going to assess for cognitive, social, emotional, and language development. They're starting to say about 2 to 3 words at a time. They're usually walking. If they're not walking by usually 12 months, but 18 months certainly would be a concern for a delay. Sometimes they can even stand on their tiptoes, throw a ball, and they start potty training. Starting to play peekaboo. They're going to imitate others, being able to wave bye-bye. Make sure to assess for their nutrition status. Are they getting fruits and vegetables? And do they eat meat? They can really start to be picky eaters, which can cause GI issues as well. Making sure we're educating the patients. They're putting everything in their mouth, and they don't necessarily know that that colorful liquid is a poison, not juice. Making sure that those things are being locked away, making sure guns are locked up, making sure that the caregivers know about water safety, drownings and burns, car seat safety again. They really should be rear facing as long as possible. At least 2 years they should be rear facing, especially with those neck muscles being really weak and underdeveloped. Can have a lot of really bad outcomes with even minor trauma in the motor vehicle crash. BLS and choking. Every caregiver should know just basic life support and how to deal with a choking child. They're still putting everything in their mouth. Big things, grapes, hot dogs, marshmallows are very common things for babies to choke because they're the exact size of their little windpipes, and they can expand as well and be just devastating. We want to assess their gauge, still making sure their vision and hearing, making sure their gauge is conjugate, no deviations in their eyes or sunsetting eyes. Early handedness is also a really big red flag for developmental delays. Poor interaction, poor fine and gross motor skills. Any weakness or abnormal posture should definitely be concerning. Reasons for these, there's a lot of reasons. Could be genetic, could be nervous system lesion, thyroid, if the baby was preterm or had asphyxia at birth, infection, trauma, or toxins. Moving on to preschoolers, starting at around 3 years to 5 years of age. They can identify their colors and their shapes. They're speaking in sentences now. They can usually pedal a tricycle. They're singing songs, using scissors, and asking why. Pretend play will really be your friend here. Just really being relatable with their common interests. Toys, clothes, books, what TV shows they're into. They'll love to tell you all about it. They're able to identify their gender roles. They're showing affection, making sure we're screening for dental health. They should be seeing a dentist twice a year. Asking the caregivers, is the patient drinking milk and water? Are they having juice and pop, and how often? Making sure we're brushing and flossing, especially as those primary teeth start to come in and they start to get closer together. Food can get stuck in there, and it's important to have that dental health. We're now going to do a formal visual acuity with a Snellen chart. If they do not know their alphabet, we can use shapes. Since they do know those now, we're going to do a full-scale acoustic test, still talk about injury and illness prevention, and BMI screenings, making sure they have the good nutrition and exercise, limiting screen times. We're still going to be, unfortunately, screening for abuse, very important in these children. Any lacerations, any ecchymosis, if they have, especially on their genitals, if they're having lacerations or bleeding or bruising. They should not have any patterns on their skin, especially on their back, behind their ears. Of course, naturally, they're going to be running into stuff. Bruises on their knees isn't that big of a deal. But if they have a big welt on their shoulder, we need to explore that. School-age children, starting at about age 5 all the way up to age 10, big age group. You're going to see big differences. A lot of these kids do develop at different ages. It's really important just to being able to discover those big delays. More than one stage would be definitely concerning. Nutrition and exercise are still really important to assess. Safety, injury and illness, constipation with that picky eating. We're going to assess cranial nerves, and it is important to start to speak to the child directly. I mean, they are a person. We should definitely get the perspective of both the child and the caregiver. We're going to see big increases in strength, especially that gross and fine motor control, coordination in sports, school performance, independence, musculoskeletal. We should be looking for leg bowing. That can trauma, bony infection, rickets, belt disease, hip disease, any limping, spinal scoliosis, which is that lateral curvature of the spine, um, and also malignancies as well. It's also important, especially in obese children, we're going to assess for that slip capro-femoral epiphysis, which unfortunately is um, more common in obese children, but not always. We're still concrete operational thinkers. Not everything's still pretty literal with them. Developing a lot of self-esteem. Um, Obesity, asthma, metabolic syndrome, insulin resistance, hypertension, hyperlipidemia, we are seeing younger and younger. It is recommended, I believe around age 10 to start screening for hyperlipidemia with it, which is a blood test. Adolescents heading into puberty, around 11 up to age 20. Um, Trust really is everything with these young people. If they feel like they're being judged, they really aren't going to tell you much. They don't want to be judged. They don't want to be shamed. They're not they're not really going to trust adults too much. Their peers, yes, everything. Their peers are everything to them. Um, Addiction, depression, sexual health are all really important things to discuss, as well as talking about these things without the parent present. Depending on the family dynamics, maybe they don't want the parents to know, and we really shouldn't be missing these things just because they don't want to talk about it in front of their parents. So sexual health, making sure birth control, condoms, making sure they have screenings, availability. Are we doing HPV vaccinations? Do we need to test for STIs? Do we need to start, talk about birth control and prevention? Um, this age group has a lot of risk taking, a lot of very high risks. They're testing their limits, and they still think they're invincible. Unless something, unless something really bad happens, they're really just going to test all those limits. We should also be talking about schooling and career goals. Are they going to college? Do they have jobs? If this patient has any chronic health concerns, we should talk about compliance. They can, for one, they can be embarrassed to ask questions, or they might rebel and stop taking their medications. Maybe they don't want to take their insulin. Maybe they don't want to be abnormal. They want to fit in with their peers. It's really important to also screen for injury and violence at home. The HEADS assessment, home, education, eating, activities, drugs, sex, suicide, safety, all important things to talk about. Making sure to focus on the patient as a person, not the problem. It is a person with the problem. The problem does not identify the person. Fast forward a couple decades, our geriatric patients are also a very special population that, a lot of times need to be treated differently than our normal adults. Functional status is huge. Loss of muscle mass, osteoporosis, arthritis, not only risk for falls, but risk for injury from these falls. Are they on blood thinners? Do they take medications that could make them dizzy or lower their blood pressure? We're going to test vision and hearing, mobility, continence, memory. We are going to use some formal testing for dementia as well as the get up and go tests. Can they chew? Can they swallow? Cataracts is really common. Any neurologic problems? Do they have a shuffling gait? It's very common for their thirst sensation to decrease, so they're at risk for dehydration and constipation. Polypharmacy, make sure to look at their medication at the Beers criteria to make sure these medications are appropriate and not interacting. A lot of this population, they don't want to be a bother. Maybe they're not going to tell you all the problems they have. Make sure to speak loud and clear to them, and just in case there is any sensory deficits. Make sure to face them and articulate well. If they do have any functional deficits, do they have help at home? Do they need assisted living? Do they need safety bars, cane and walker, and all those things that can just keep them safe? In conclusion, nurses and providers, we should be assessing our patients per their developmental level. Child development is very predictable and typically linear. Place your child within that developmental trajectory. Notice any deficits, any missing milestones should be red flags, and expert referral. Thank you.